Okay, I'm going to kick it off. My name is Dr. Erik Koorneef. I'm the Executive Director of Research within the Institute of Healthier Living Abu Dhabi. And it's a great pleasure to be here today with this webinar organized by Single Run Biotechnologies and our partners in Omics in Abu Dhabi, United Arab Emirates. So for some kind of messages about how we run this webinar, we have about an hour to cover a lot of different topics, and Dr. Rebecca Robbins has joined us here today as a special guest for this. So before I hand over to Rebecca, I'll introduce her to you all. I'll also make sure that you understand that there's questions and answers at the end. You can leave them in the question and answers section down below, in the banner below. And yeah, that's the main message for today. So it's a pleasure to welcome you all here. And thank you, Dr. Rebecca, for joining us today. Rebecca probably doesn't need much introduction. Sleep scientist. I'll for the benefit of the audience, I'll give you the introduction. Professor in medicine with Harvard Medical School and scientist also at Brigham and Women's Hospital. Dr. Robbins holds a PhD from Cornell University, and her research, which is very well cited, uses marketing and novel communication tools, technologies to design persuasive behavior changes, interventions to improve our health and sleep in particular. So we are being recorded, so hopefully that's okay for you. And we will make this available on YouTube and other channels as well. Dr. Robbins' research has appeared in many peer-reviewed publications and news publications. And in 2011, Dr. Robbins co-authored a book on techniques for how to get good sleep entitled Sleep for Success with Dr. James Maas. So, Dr. Rebecca, before I hand over the mic to you, I will just present a little bit, if it's okay with you, on the Institute for Healthy Living and the research we're doing in our institute. So I'll just share my screen for a bit and present my short presentation before I hand over, because it's been a pleasure working with you and collaborating with you. And I hope you can see my screen. And yeah, as the Institute for Healthy Living Abu Dhabi, or ILAD, we have a growing research department and a growing number of research studies. And the one that Dr. Rebecca Robbins is going to present on is a very important one for us. So we're helping people live healthier lives. We're licensed by the Department of Health in Abu Dhabi, one of the first in the world to get a license as specialized healthy longevity medicine center. And we have a large team of about 12 research members and still growing, around 12 research studies ongoing. Thanks to Dr. Rebecca's efforts and her team's efforts, we've recruited many participants, including the 2,200 plus participants for the Ramadan study. We've already had 6 publications. We have a fully fledged IRB, Institute Research Board, and we have a very active scientific advisory board. We focus on all aspects of healthier living, including genomics, sleep, diet, and lifestyle medicine. We have a number of key global collaborations and local, Single Run being one of them, as we are hosted by them today. And we want to strengthen that. And Harvard, we're very proud to be part of their work as well through Dr. Rebecca Robbins. And Omics you've heard about, I hope. If not, you'll hear about them a little bit more today. So we have a wealth of experience in terms of the best and the brightest when it comes to science. And Dr. Rebecca Robbins is part of this scientific advisory board, including Dr. Nicole Sironton, who is the scientific advisory board chair, as well as the CEO of the Institute for Healthy Living Abu Dhabi. We've completed around 4 studies so far, all related to healthy living and lifestyle management. And we are currently undertaking 5 studies spread out over 5 different groups. So we have one on the Emirati Genome Program, which consists of actually 4 separate studies. We have a human phenotype project together with the Mohammed bin Zayed University for AI. We have a study for IFAS, which is a lifestyle-based study. And we have a Ramadan health study, which we'll talk about today. And finally, last but not least, we have a culinary medicine program. So just very quickly, a little bit about myself, and I'll stop sharing my slides now and hand back over to Dr. Rebecca, um, and for her to take it forward. Dr. Rebecca, I hope you got that message, and hopefully you can take it over and present on your study, and especially around sleep medicine. Thank you.
My pleasure. Thank you for that warm introduction, Dr. Erik. And the pleasure has been all ours for our collaboration. And I'm excited to share a little bit more this morning, this afternoon, this evening, as you so aptly said, put it, Dr. Erik, on kind of the science behind our exciting study that is exploring the health of Ramadan observers and exploring the possibility of methods for optimizing health and well-being of Ramadan observers during the holy month. I will just again acknowledge this really robust collaboration we have between my laboratory at the Harvard Medical School and the incredible team, Dr. Erik and others at the Institute for Healthier Living, Abu Dhabi. So our learning objectives for today are fourfold. First, to define a healthy sleep system and explore the prevalence of sleep health or poor sleep health in our global society. Consider the changes that take place during the holy month of Ramadan to sleep, meal timing, and light exposure. Then to understand the relationship between disrupted or fragmented sleep and potentially mistimed meals and light exposure and cardiometabolic health. And then learn the objectives of our Ramadan health intervention. Learning goal number one, defining a healthy sleep system. When we talk about sleep, we like to offer this concept of sleep health that articulates the important elements of a healthy sleep system. I think the usual one that we all think of is sufficient duration, but a healthy sleep system actually has many components. A healthy sleep system is comprised of consistently timed sleep, not only getting enough sleep, but falling asleep at as close to the same time and waking up as close to the same time. Day after day is vitally important. We want sleep that is satisfactory to the sleeper. We want someone to wake up and tell us that they feel restored and satisfied with their sleep. We also want sleep that supports daytime alertness. If a person or a patient is consistently reporting that they are excessively sleepy or lacking daytime alertness, then that might be cause for concern. We ideally also want consistently timed and appropriately timed sleep over the course of our night that's ideally aligned with our internal circadian rhythm, which we'll talk about a little bit during the lecture today. We also want high efficiency sleep. That refers to the time that you spend in your bed to the time that you spend sleeping. If the time that you spend in bed is much greater than the actual time that you spend sleeping, then that will be a lower, what we call efficiency score, and something that we would want to nudge higher. Then lastly, we of course want a sleep duration of a sufficient amount for the vast majority of adults. That is somewhere between 7 and 9 hours. And we'll talk a little bit about the insufficient sleep duration crisis we have in our global society. And it truly is increasingly approaching the level of concern from the standpoint of public health. Sufficient sleep is ideally about somewhere between 7 to 9 hours for optimal health and well-being in adults. But unfortunately, in nationally representative samples in the US, about 2 in 3 adults report consistently falling short of that biological need, with many more falling in the fewer than 7 or greater than 9 category. In addition to not getting enough sleep, one of the markers of poor alertness or low satisfaction with sleep that our lab has developed is this concept of restorative sleep. We want a sleeper to wake up and tell us that they feel refreshed by their sleep, that they feel that their sleep is restorative. So we've developed a 9-item questionnaire called the Restorative Sleep Questionnaire that assesses several different domains, such as feeling rested and alert after waking, sleep that provides physical and energy restoration, provides mental clarity, improves mood, and provides an overall sense of restoration. But in the US, when we look at a nationally representative sample and responses to this questionnaire, we see that many are falling short of this mark. Only about 1 in 3 adults reports that their sleep is restorative. Now, what about sleep disorders? There are more than 90 differentially diagnosable sleep disorders. One of the most common is insomnia. Insomnia is characterized by a repetitive complaint of difficulty falling asleep, difficulty maintaining sleep, waking up too early, or sleep that's simply non-restorative. And when those complaints are observed night in and night out over the course of 2 weeks or longer, that can include an insomnia diagnosis. Now, in the US, in a nationally representative sample, we say that about 23% of adults suffer from a clinical diagnosis of insomnia. Another common and concerning sleep disorder is called obstructive sleep apnea. This is a description and a visual display of this disease where a sleeper here takes air in without obstruction in a healthy person. You see the arrows indicating the flow of oxygen over the course of a night. On the right-hand side is an obstruction of the airway, and this is like of obstructive sleep apnea. Air cannot go through the passageways you see due to this obstruction, so the sleeper has to wake up to resume breathing. The symptoms of this disorder are excessive daytime sleepiness due to this repetitive awakening that we see in patients that are suffering from obstructive sleep apnea. We also see loud snoring, pauses and breathing over the course of the night, and also choking or gasping at night. In the US, in nationally representative samples, we have data to show that about 32% of adults have obstructive sleep apnea. What is concerning is about 80% of those patients remain undiagnosed. So, without the successful treatment of obstructive sleep apnea, we cannot have sleep health. So, it's one of the key priorities of our laboratory when we explore sleep is to understand insomnia and sleep apnea diagnoses. So much of the data I've showed so far is in the US. What do we know about sleep in the UAE, where our collaboration with the Institute of Healthier Living is taking place? Some of the cohorts that we found in the published literature are largely derived from convenience samples or student samples, which I will share with you this morning. One of such samples is a convenience sample of adults in Sharjah, and the sample is 407 individuals. And in this study, they collected surveys assessing sleepiness and obstructive sleep apnea risk. The result of this study revealed, in terms of sleep duration, the vast majority are falling below that recommendation of 7 to 9 hours. Only 30%, similar to the US, were obtaining sufficient sleep. Many more are obtaining shorter than the recommended duration. 43% are getting 6 to 7, and 24.4% are getting fewer than 6. 2.5% are getting 8 or more hours. And unfortunately, we also see significant reports of sleepiness. 1 in 3 reports reported being refreshed by their sleep, which means 2/3 are feeling non-restored by their sleep. This current survey also assessed symptoms of sleep apnea, and it found that there were 34.2% of the population that were reporting being snorers, 45% non-snoring, 20% were unsure. But in those that reported snoring, the researchers investigated an evidence-based battery for sleep apnea risk, and they found that 43% of those that reported snoring were at very high risk for sleep apnea and 56% low risk. But this 43.2% is at high risk for sleep apnea and deserving of care. In another sample, a convenience sample of nursing students, 177 were sampled, 30.6% reported a sleep disorder, and of that 1/3, the most common sleep disorder was insomnia. 38% reported this diagnosis or being at risk for the diagnosis, and 25% reported being at risk for obstructive sleep apnea. So these were two of several studies that have been published on sleep in the UAE. But one of the conclusions here is that the vast majority of research has drawn from convenience samples. So there is an opportunity to leverage robust public health surveillance methods to develop better, more precise population estimates of sleep in the region. The second learning objective is to understand some of the possible sleep, meal timing, and light exposure disruptions that take place during the holy month of Ramadan. So, to go through this exercise, let's consider a sleeper who's generally healthy and they're sleeping between 7 and 8 hours at night. They're falling asleep at about 11 o'clock or 23 military time and waking up at about 7 a.m. in the morning, allowing for 7 to 8 hours of sleep duration. When we introduce the Ramadan observation interval, we often see several disruptions or changes, alterations to that consistent block of sleep. The first is a delay in bedtime of about several hours, with a potential fall asleep time around 1 o'clock in the morning, and then a wake up time at 5 o'clock in the morning to observe Fajr and take suhoor before awakening and resuming the fasting for the Ramadan holy month. So we fragment sleep, we delay bedtime, and we also increase compensatory sleep during the afternoon with a nap. Now, as far as meals go, this person hypothetically could be taking dinner around 6 or 7 p.m. in the evening, potentially having a small snack before bedtime, waking up for breakfast around 8 a.m., potentially a small snack in the middle of the morning or the afternoon, a substantial meal interval during the lunchtime, and then the process starts again. If we introduce the Ramadan interval, the incredibly beneficial practice of fasting and a breaking of the fast with an iftar, potentially an evening snack and a light meal before going about the day and resuming the fasting interval, resulting in a shift in the eating window. Now, if we look at light exposure, let's take that same typical person, and in their typical schedule, they likely expose themselves to dim light in the evening, which is necessary for the secretion of melatonin to allow for sleep to follow, followed by excessive bright light exposure, typically broad daylight spectrum light exposure between the hours of 7 a.m. and 6 p.m. If we introduce the Ramadan schedule, that might likely shift with several phenomenon taking place, which include evening light exposure due to socializing, potentially pre-dawn screen exposure. Screens can emit blue daylight spectrum light, which can alter circadian rhythms. And we also observe a reduction in light exposure during daylight hours. Now, these systematic changes take place over the course of a 30-day interval during the observation of Ramadan. Now, let's consider some of the health impacts of these schedules. On the one hand, the overwhelmingly positive benefits of Ramadan include spiritual growth and development, the really robust evidence-based practice of fasting, which we have known cardiometabolic health improvements, or which present these known cardiometabolic improvements. But when Ramadan is practiced, potentially with small alterations that could exacerbate excessive sleep fragmentation, potentially result in non-restorative sleep, light exposure at missed or inappropriate times, and inappropriately timed meals could potentially increase cardiometabolic concerns. Now, if we take a look on the right side of the equation and the benefits of Ramadan, I'd like to call on the intermittent fasting literature to cite some of the potential and dramatic benefits of Ramadan observation. And to do so, we take a look here at intermittent fasting. There is a growing literature on intermittent fasting, which refers to an eating pattern that institutes or instructs a patient to eat within a specific window, narrowing the time with which they're eating, typically to a window that is 10 hours or less. This is much like what a person or a patient is doing during the Ramadan interval. They're fasting for a longer than typical period of the day and restricting their caloric consumption to a narrow window. In what I'm about to describe is a meta-analysis. So they combined 14 studies that looked at various intermittent fasting protocols and the resulting cardiometabolic benefits. This was published in the Frontiers of Nutrition not too long ago. I want to call your attention to one of the benefits in particular, which was rather profound. Over these 14 studies, the researchers investigated changes in the observation interval when an intermittent fasting protocol was introduced over a 2 or more week protocol. There was a systemic reduction in systolic blood pressure to the tune. The effect size was negative 2.14 and a significant p-value here over these 14 studies. There was also a significant observation and a reduction in diastolic blood pressure, resulting in a significant cardiometabolic benefit to those that were introduced to these intermittent fasting protocols. The one downside of applying this logic to the Ramadan interval is that largely these patient populations introduced these intermittent fasting schedules within their habitual fall asleep and waking times. One of the significant kind of differentiating factors between such a Ramadan or such a intermittent fasting protocol and a Ramadan protocol is it takes the benefits of fasting, but it flips a schedule so that sleep and light exposure and meal timing are now taking place during a fundamentally different window. So our study set about to contribute to this body of knowledge. How can we understand the benefits of intermittent fasting schedules, such as those introduced during Ramadan, but also understand some of the sleep, meal timing, and light exposure fundamental shifts and changes that are happening? And to help us understand and develop our hypotheses, our third learning objective is to call on some of the literature that has looked at disrupted sleep and cardiometabolic health. So, overall, in our research, this is one of the driving features to all of our protocols in our laboratory, which is the fact that poor sleep or disrupted sleep health can increase risk for cardiometabolic disease. And I'm going to run you now through a number of the protocols that provide some insight on these associations. Before we dive in, I'd like to draw your attention to one of our fundamental systems in our biology, which is our appetite regulation system. And it's governed in large part by two hormones, ghrelin and leptin. And these two hormones live in the lining of the belly or our adipose tissue in the case of leptin. Ghrelin operates in a neurotransmission fashion, sending a signal from the lining of the stomach to the brain to signal hunger. So before a meal, ghrelin is, of course, very high, signaling hunger that will decline after a meal is consumed. Now, ghrelin and leptin operate in much of a yin and a yang phenomenon where leptin signals to the brain after a meal or midway through a meal, I've had enough to eat, and suggests or sends a signal to stop eating. We refer to leptin as the satiety hormone, signaling satiety, decreasing appetite, and resulting in a cessation of consumption of food. Now, let's look at this in a controlled experimental setting in participants who were recruited for an overnight PSG study, which stands for polysomnography. When we welcome patients into our laboratory here at the Harvard Medical School or elsewhere, we often have a very rigorous and controlled protocol, and we are able to really systematically understand sleep. When we recruit patients for such a study and we allow them to sleep for 2 nights with a more than sufficient sleep opportunity of 10 hours, allowing them to be, in other words, sleep satiated, so very well rested. And then that's followed by 2 nights of insufficient sleep, so 4 hours or less. What happens in those patients after the introduction of a short sleep schedule? They have an increase of 28% in ghrelin, which, as you remember, is the hunger hormone, signaling greater experiences and sensations of hunger. But unfortunately, that's coupled with a reduction in leptin. So there's an 18% reduction in leptin, which, as we just learned, is the satiety hormone. And so let's look at this in a very controlled fashion. What happens when a person is kind of restricted on sleep to their nutritional, their choices and their overall intake. So those 12 men with a normal body weight were allowed those 2 nights of more than sufficient sleep duration, and then introduced this very short sleep duration protocol. During this very controlled setting where we see a normal sleep episode, allowing them to eat breakfast, lunch, a light snack, and dinner, and then sufficient sleep duration followed by the same nutritional opportunity, and then sleep satiating them, compared to a sleep restriction protocol where we have the same eating opportunities. Timing has been retained as normal during the normal sleep schedule, and then we simply reduce their sleep schedule. I'd like you to invite you to recall the Ramadan interval where we delay bedtimes and we bring a patient and we wake them early for the Fajr prayer. This protocol in some ways looks very similar to what we introduce in often during the Ramadan protocol. And then we offer the same opportunity for breakfast, lunch, and dinner. Of course, slightly different than the Ramadan protocol here, allowing for habitual meal times during a person's habitual daytime. And in this within-person study, we randomize them to sleep satiate them or sleep restrict them and observe their objective nutritional intake. When we compare the normal sleep window with the sleep deprivation protocol, we saw significant differences in the overall 24-hour day, with a person consuming on average 560 more calories during the sleep restriction window as compared to the normal sleep schedule. We also saw several changes. First, to their hunger. We saw more experience, excuse me, before hunger, we saw overall more sleepiness. The normal sleep window is observed here and documented, their overall sleepiness with the dark line. And then the sleep restriction protocol is the light, non-shaded line. So as you can see, significantly elevated sleepiness over the course of the typical day after a sleep restriction protocol. And then compared to the healthy sleeper, which is in the dark shaded line, the motivation for physical activity was systematically higher over the course of the day following a sufficient sleep opportunity. Following the insufficient sleep opportunity, the sleeper had much less motivation for exercise. And then hunger, we saw significant increases in reports of hunger, especially after waking in the two different protocols here. The dark line is the normal sleep opportunity, and the non-shaded line here is the sleep restriction protocol with much higher ratings of hunger significantly after waking during breakfast and then also during the dinner opportunity. And this is because a person with such a sleep restriction protocol, we were looking at previously, was primarily due to strictly sleep restriction. But now I'd like to invite you to consider circadian misalignment. Up until now, we've been talking about insufficient sleep duration, but now I'd like to consider a person who is aligned with their circadian rhythm, falling asleep with approximately with the sun and waking up approximately with the sun. This person has a very robust and consistent sleep schedule, picking a bedtime, let's say 11 p.m. and waking up at 7 p.m. It doesn't necessarily when in the nighttime a person is sleeping, as long as they're able to get some blue enriched light during the day and enter a dark environment. But the message here is this person has a rhythm that is very well aligned. And what we're modeling here is the hormone melatonin. Melatonin is secreted in the brain when we enter a dark bedroom environment, and it is shut down when we expose ourselves to light and, importantly, maintain consistency in our sleep schedules. So this is a beautiful hormone profile of the hormone melatonin in such a sleeper, who we refer to as circadian aligned. Now, when we introduce misalignment in that same person, we expose them to sunshine in the middle of their biological night. Melatonin is low and it's blunted over the course of the night, even if they're making up some of their lost sleep, potentially due to naps, and recovering lost sleep due to sleep during their otherwise habitual nighttime. Their melatonin profile will be blunted. Now, if we look at blood pressure, and if you kind of consider the left quadrant here before the right quadrant of the screen, we're looking now at blood pressure. Blood pressure reaches its lowest point in the 24-hour day during our biological night. We see this really healthy, significant dip in blood pressure over the course of the habitual nighttime. We wake up, and any clinician on the line will know that if you welcome a patient with high blood pressure or normal blood pressure into the lab for blood pressure measurement, first thing in the morning, you might see a natural elevation, potentially driven in part due to increases in cortisol, cessation of melatonin as well here on the upper quadrant, and then maintaining a healthy, hopefully, blood pressure over the course of the night. And then again, that significant drop in their blood pressure during their biological night. Now I'd invite you to consider the right quadrant of the screen. Excuse me. The right quadrant of the screen, which introduces circadian misalignment, a protocol not too different than Ramadan, where we expose a person to light during their biological night, invite them to sleep during their habitual wake times, and you see attenuated dipping in blood pressure. So where we get this really nice nocturnal dipping, we get a blunted dipping in blood pressure, what resulting in elevated blood pressure over the course of the rest of the day in their blood pressure profile over a 24-hour day. And that's because our biology is intimately connected to the pattern of light and darkness in our environment. Human beings have evolved over hundreds of thousands of years to adapt to life on Earth and an approximate 24-hour day. Light information comes in through the eyes and triggers a small region of the brain called the suprachiasmatic nucleus. In the sleep and circadian literature, we refer to this as the central circadian pacemaker, from which that pacemaker emanates sounds and signals to peripheral cells in the tissues in almost every single organ in the body, which operate also in an approximate 24-hour cycle, signaling to these organs to fire or retire certain hormones over the course of the day, signaling vital opportunities for virtually every corner of the body to rest at predictable times during the day or fire during predictable times of the day. Without consistency, without routine, these cells operate in a suboptimal fashion. Some of the usual suspects that we walked through are melatonin, blood pressure, but there are many, many more that operate in this very routinized fashion. Anyone who's traveled across time zones or potentially introduced a Ramadan observation window knows all too well that the first days are very difficult to adjust to that systematic, that complete, systematic change to virtually every routine of our behavior, which then triggers internal routines of our very selves. So, the bottom line is that many hormones in the body and the brain are sleep dependent. And when sleep or circadian rhythms are disturbed, such as when we introduce a jet lag protocol or bring a person into a new time zone, or we introduce a Ramadan interval, energy expenditure and hormone profiles are also disrupted. So, one more example of this is a well known study in the field that looked at the role of insufficient sleep and circadian misalignment in some of the key hormones that matter for our ability to maintain a healthy weight. So, ghrelin is the hormone that we discussed earlier. That's the hunger hormone, and it operates in this very rhythmic fashion. As you see on the left-hand side, this is a person who's allowed to follow their normal, let's say, pattern of breakfast, lunch, and dinner, and then sleep opportunity here marked in gray. Naturally, you would expect for ghrelin to be very high before breakfast. We wake up and what? We are hungry. Of course, we've been fasting during our habitual sleep opportunity. And then ghrelin goes down after we've consumed breakfast. It goes up again around lunchtime and then declines after breakfast and then increases during right before dinner and then declines, and then it reaches its lowest overall period in the 24-hour day right before we wake up. And then your leptin profile has a very similar circadian profile. Levels of leptin are higher during sleep than wakefulness, and then peak during the beginning of sleep and decrease right after. So our feelings of satiety are very low when we wake up. Then what happens when we introduce a circadian measurement, which we call a constant routine? This is an opportunity where a person is offered little, like what we'll call snacks of sleep over the course of the day without this consistent block of time, nocturnal sleep. In other words, we completely circadian misalign a person, giving them opportunities for very small bouts of sleep instead of that one consistent block. And what do we see when we look at this consistent, constant routine, completely disrupting a person's circadian rhythm and profile? We see marked elevations over the course of a 24-hour day of ghrelin, which, as you remember, is the hunger hormone. Without the natural ability to replenish ghrelin at night and then operate in this cyclical fashion as we eat and then kind of stop eating, eat and then stop, ghrelin remains consistently elevated. Similarly with leptin, we see a consistently elevated leptin profile so that levels of ghrelin increase over the biological day, as do when the levels of leptin decrease across the biological night and increase along the biological day, staying in this consistently elevated nature. Another way that we can understand the consequences of some of the disruptions to our sleep and daytime schedules is the literature on what we call social jet lag. There are many times I think I would invite you to reflect on your own day, kind of typical week. If you maintain a very maybe, routinized Monday through Friday routine, and then potentially you extend your sleep times on a Friday or Saturday night, often for social reasons. And believe it or not, some of these social schedules actually self-impose feelings of jet lag. So we refer to this in the literature as social jet lag because we often impose jet lag symptoms, typically for social reasons. And what we mean experimentally, if we were to manipulate or induce social jet lag, we would take the mean sleep time of a school or workday protocol, potentially falling asleep, say at 10:30 at night, waking up at, say, 6:30 in the morning. This is a really beautiful schedule. And say a person maintains that Monday through Friday, and then Friday night rolls around and they have a social obligation or late dinner at a fabulous new restaurant in Abu Dhabi or Dubai, and we delay our bedtime and wake times, often referred to a lion in many European countries or sleeping in here in America. The way we calculate someone's social jet lag or the extent to which a person has self-imposed these jet lag-like symptoms is if the mean time of your sleep window during your school or work protocol varies significantly from your mean sleep time of your weekend protocol. And when that time is significant, more than 1 hour, we typically estimate social jet lag being introduced and the risk of circadian misalignment. Now, in this very elegant paper, these researchers analyzed participants from a nationally representative sample in New Zealand using really robust public health estimation strategies to approximate the population. And they modeled social jet lag by survey and measures of obesity and cardiometabolic measures captured by blood sampling. Now, what they found in social jet lag, those individuals that were demonstrating social jet lag with a significant difference between a weekday and a weekend timing of their sleep and meals, they found that in non-obese individuals, there was significantly less social jet lag observed, and those that we define unhealthy obese because we like to distinguish between healthy and non-healthy obese. There could be a patient with obesity that has their blood biomarkers look healthy and other measures, they have their condition under control. An unhealthy obese patient would be an individual that's lacking some of those safeguards. And in these populations, there is a significantly increased risk for social jet lag, typically demonstrating 1 hour or more social jet lag in a typical week. So obesity was associated in this study with greater observation of social jet lag or circadian misaligned schedules, giving us a signal that such a schedule does offer kind of hindrances to our cardiometabolic health. Using their blood biomarkers, they analyzed inflammatory markers, finding an association between more than 1 hour of social jet lag and C-reactive protein and glycated hemoglobin.
So I think I've come to the end of this lovely conversation and this beautiful presentation. So thank you very much again, Dr. Rebecca Robbins, for joining us today. I think I also want to thank the organizers, Adiomics and Single for initiating this. I hope you all enjoyed it.
Thank you again, Single Ron and Adiomics. I really enjoyed the opportunity.
Yeah.